This is a presentation on the basic pharmacology of inhaled anesthetics, part one of a two-part series, November 2015, as part of the University of Kentucky Department of Anesthesiology didactic series. My name is Randall Schell. We'll first look at the American Board of Anesthesia in-training exam keywords from 2007 all the way up to current 2015. And break it down into the major categories here of chemistry, MAC, physics, and uptake and distribution, and on the next slide into physiologic effects, toxicity and metabolism, and nitrous oxide as a standalone discussion. Under chemistry, MAC, and physics, you can see topics such as the Meyer-Overton correlation, which refers to lipid solubility and potency correlate, blood gas coefficient, lower the blood gas coefficient, and solubility of the inhaled anesthetic, the faster the onset and offset, some of the factors affecting MAC, the concept of MAC as a partial pressure rather than a percentage, some of the things such as hyperbaric chamber or other factors affecting anesthetic depth, vapor pressure of inhaled anesthetics, calculation of vaporizer output, when you know the vapor pressure, what happens at altitude, what happens if you misfill a vaporizer. And then under uptake and distribution, there are multiple keywords, including right to left shunts, concentration effect, FA over FI curve for volatile anesthetics, second gas effect, solubility coefficients and how it affects uptake and distribution, time constant definition, and how some things like VQ mismatch affect uptake and distribution. Dr. Gene Hessel will be giving a presentation specifically on uptake and distribution, and I will therefore touch on it superficially rather than in depth. Also between 2007 and 2015, under physiologic effects of inhaled anesthetics, you can see the effects of inhaled anesthetics on CMRO2 of the brain, or oxygen use of the brain, cerebral blood flow, cerebral perfusion, cardiovascular effects of desflurane, probably related to its sympathetic stimulation, bronchodilation, all of our inhaled anesthetics are bronchodilators, isoflurane and ventilation probably had something to do with increasing respiratory rate, decreasing tidal volume, and decreasing alveolar ventilation. The fact that inhaled anesthetics impair the ventilatory response to hypoxia, even at low subanesthetic doses. The fact that inhaled anesthetics potentiate muscle relaxants. And then under toxicity and metabolism, CO2 absorbers and some of the bad things that happen in them, including carbon monoxide production, and compound A occasionally comes up also. Malignant hyperthermia is a disease of anesthesia specifically, in which volatile anesthetics and or succinylcholine are the triggers. And then there's a whole section on nitrous oxide, expanding closed air spaces, expanding sulfur hexafluoride gas that can be ejected in the back of the eye during retinal detachment surgery, and therefore we would want to avoid it, and the effect of nitrous oxide on distending bowels. So as an outline, as we start, in blue represents part one, in green represents part two of this two-part series. We'll talk about chemistry, define what general anesthesia is, and some understandings, especially our current understanding of what general anesthesia is and how it occurs. Some characteristics of inhaled anesthetics, including MAC, vapor pressure, blood gas partition coefficient. Finish up the first part with some superficial discussion of uptake and distribution. Begin our part two with the physiologic effects, respiratory, cardiac, neurologic, etc., the disease malignant hyperthermia, some of the toxicity and metabolism issues, a standalone discussion of nitrous oxide, and then briefly touch on some an anesthetic of the future, xenon. So let's begin first with a slide showing the development of anesthetics over time from the mid-1840s to current. You can see that we still use nitrous oxide. It was developed back in the 1800s, but many other ones went by the wayside, dots without names beside them. And in the mid-1950s, when carbon fluoride chemistry was better understood during the time of nuclear development and nuclear chemistry research, some good things came out of it are inhaled volatile anesthetics. Halothane and fluorine have historical importance. Mostly isoflurane, desflurane, sevoflurane are a common 3 volatile anesthetics used today. And xenon is more of a research anesthetic and may be used in the future if some of the problems with its delivery and recovery can be managed. So if we go back to halothane's development, it seemed like a great anesthetic because unlike many of the other ones that were developed in the 1850s to mid-1900s, they were flammable, things like cyclopropane. And so when halothane came along, which was inflammable but caused some dysrhythmias, it wasn't the optimal anesthetic. Methoxyflurane came along a little later, and it caused high output renal failure because of free fluoride production. Enfluorine came along, and there was also issues with fluoride and seizures if it was turned up. That is, the concentration increased very quickly. And isoflurane came in the early 80s, and we thought we'd hit nirvana, but Sevo and Des came along later, showing that we have anesthetics that have a faster onset and offset than isoflurane at some costs. When we look at the chemistry of inhaled anesthetics, up at the top you can see nitrous oxide is an inorganic compound, while xenon is a inert compound, noble gas. Halothane is a halogenated alkane, has chlorides, bromides, and fluorides around it. And we are using today ethers still, but very special ethers, and it's fluorinated ethers. And you can see that isoflurane, desflurane, and sevoflurane are ethers, but they have lots of carbon fluoride bonds, which make it more stable and not flammable. So if we look at these structures in detail a little bit more, you can see desflurane and sevoflurane at the bottom. Desflurane has very low blood gas solubility and very fast onset and offset, making it clinically very useful inhaled agent. It is very resistant to metabolism, but it needs a special vaporizer to deliver it because of its high vapor pressure. While sevoflurane initially was noted to kill kidneys in rats because of something called compound A, a metabolite of it. But in humans, that has been shown to not be a big issue. The sevoflurane is used frequently today for inhaled inductions, has a low blood gas solubility, relatively fast onset and offset. These carbon fluoride bonds and the fluorination of these compounds increases the potency, decreases the flammability. So even though we're still using ethers, we're not using flammable, explosive ethers. Looking at Des and sevoflurane, are most commonly used inhaled anesthetics. Both have a low blood solubility, fast onset, precise control, can change the concentration rapidly in a patient, and prompt recovery. But there's some problems. And with Des, there's airway irritability, sympathetic nervous system stimulation, the formation of carbon monoxide in the CO2 absorber. You have to have a new vaporizer because of its high vapor pressure to deliver it. While sevoflurane has some other issues, one being a product of its breakdown metabolism called compound A, and both Des and Sevo are relatively expensive compared to isoflurane. What is general anesthesia? Oliver Wendell Holmes called it privation of the senses, or loss of sensation. It's a reversible state. We often think of it as having several components. One of those is muscle relaxation. One of them is loss of consciousness. Another is blocking autonomic reflexes, so we don't get tachycardic and hypertensive when we have nociception or painful stimuli, and analgesia, or blocking painful stimuli. Those components we think of as the major components making up general anesthesia. But what is the anesthetic state then? And for experimental purposes, we define the anesthetic state as immobility and amnesia. So if a patient doesn't move and doesn't remember anything, it's a successful anesthetic, somewhat tongue-in-cheek. Immobility in response to surgical stimulation is really a spinal cord mediated event, and MAC is a measure of that, which we'll talk about in a bit here. In fact, you can decerebrate a rat and clamp their tail before and after decerebration, and the amount of anesthetic to keep them from moving to that tail clamp is the same, basically, suggesting that MAC is really spinal cord mediated, immobility is spinal cord mediated. While remembering things obviously has to involve structures in our brain that are very important to processing memory, amygdala, hippocampus, and cortex. These supraspinal structures are likely the target for causing amnesia. Inhaled anesthetics causing amnesia for intraoperative events. Going back again a little bit historically, there was a principle called the Meyer-Overton principle in an attempt to come up with a unitary hypothesis or common mechanism of how general anesthetics worked. And you can see in this graphic of the y-axis showing concentration required for anesthesia, and on the x-axis lipid solubility. As lipid solubility goes up, the amount required to provide anesthesia goes down dramatically, whether it's ethanol, an IV anesthetic thiopental, or an inhaled anesthetic like isoflurane. This was an attempt to say, lipid solubility, the lipid membrane itself, is the target potentially of general anesthetics. And when we looked at oil gas solubility, listed here in desflurane as 19, isoflurane as 91, you can see that isoflurane has a much higher oil to gas solubility or lipid solubility, and it is more potent than desflurane. It takes 6.6% to provide 1 MAC, or to keep 50% of patients from moving to incision, while isoflurane is approximately 1.2%. So isoflurane, much lower concentrations required to keep patients from moving to incision. Interestingly, the solubility of inhaled anesthetics, des, sevo, and isoflurane in olive oil tells you about its potency. The more soluble it is in oil, the more potent it tends to be. What's the mechanism of action of inhaled anesthetics? The old theory of expanding lipid membranes and altering proteins in lipid membranes has been replaced by the majority theory that inhaled anesthetics exert their effects by binding directly to ion channels, like ligands binding to a receptor. And there's multiple receptors involved in this, including inhibitory channels, such as GABA and glycine, excitatory channels, which might be blocked, like NMDA, and affecting the release of other neurotransmitters. The mechanism of general anesthesia is incompletely understood, however, even though we can say that it likely affects receptors such as the GABA receptor, the glycine receptor, the NMD receptor at the bottom, potentiating the GABA and glycine and inhibiting the NMDA receptor. We also know that the more lipid-soluble an agent, the more potent it is. But a overall theory of how general anesthesia works is still being studied and will hopefully develop in the future. How do we know how much anesthetic to give? Assessing the adequacy of depth of anesthesia. When you're in the operating room and a noxious stimulation occurs, such as incision, surgical incision, sometimes physiologic changes like blood pressure, heart rate, respirations, if neuromuscular blockade is not being utilized, will increase. And we'll say, the patient's not adequately anesthetized, we need to increase the depth of anesthesia. So physiologic changes are part of assessing adequacy of depth of anesthesia. The electroencephalogram pattern. There are processed EEGs, such as the bispectral index as well as others, that attempt to provide an EEG-based number to tell us how deeply anesthetized, or probably more appropriately, hypnotic asleep a patient is. And then population statistics, which really is what MAC is. And so as we talk about MAC, think of it as a population statistics. How much does it take in the general population to keep a patient from moving to incision? And so MAC is defined as the concentration of the inhaled anesthetic in the alveolus of the lung at steady state as measured by our anesthetic gas monitors from sampled expired and expired alveolar gases at 1 atmosphere, at which 50% of patients will not move to surgical incision. So the graphic here is showing a vaporizer, vaporizing the inhaled anesthetic, expired concentration, is what's important. We're measuring that with a monitor. It's measuring the alveolar expired concentration. And when we reach a concentration at which 50% of patients don't move to incision, we turn that MAC. Luckily, the standard deviation of MAC is quite narrow. If we line up the MAC of our inhaled anesthetics, you can see that MAC is a measure of potency. And in humans, it's determined by response to surgical stimulation incision. In rats, it's frequently determined by a tail clamp technique, which is the noxious stimulus. But here you can see that nitrous oxide requires 110% to provide 1 MAC, which should tell you that you can't do that. You have to have some oxygen, and only under hyperbaric conditions could you provide adequate nitrous oxide to provide 1 MAC. Desflurane, not very potent, requires 7% to provide 1 MAC. Sevoflurane, approximately 2%, and isoflurane, approximately 1.2%. That's what keeps 50% of patients from moving to incision, but there are variations in MAC. One is MAC awake, or the alveolar concentration at which 50% of patients will awaken to calling out their name. And with Des, Sevo, and Iso, this is approximately 1/3 of a MAC. This is assuming that there are no other anesthetics on board. Obviously, the patient's not paralyzed, no opioids, no benzodiazepines. At approximately 1/3 MAC, the patient will respond to command. It takes 1 MAC to keep 50% of them from moving to incision, but if you just go up a little bit to 1.3 times MAC, or in the case of desflurane, 1.3 times 7, in the 9% range or so, you are getting, at that point, 95% of patients to not move to incision. So small change, large effect. And then alveolar concentration, which blocks adrenergic response. You have to go up to about 1.5 times MAC to prevent the adrenergic norepinephrine response that occurs to stressful stimulation in 50% of patients. So we'd line it up as MAC awake, 1/3 MAC, MAC is 1, 95% of patients not moving to incision, 1.3 times MAC, and blocking adrenergic response, 1.5 times MAC. Now we've expressed MAC as a percentage in a previous slide, but really we should think of MAC as a partial pressure. So in the case of desflurane, if the MAC was 6 or 7%, let's just say it's 6% right now, 6% of what? Well, 6% of 1 atmosphere, assuming you're at 1 atmosphere, is about 45 millimeters of mercury. So the MAC of desflurane could be said to be 6% at 1 atmosphere, or probably more appropriately, 45 millimeters of mercury. While sevoflurane, 2%, approximate MAC, 2% of what? 1 atmosphere is about 15 millimeters of mercury, so we could say the MAC of sevoflurane is 15 millimeters of mercury, and isoflurane, same idea, 1.2% times 760, or approximately 9 millimeters of mercury. So when we think of MAC, you can think of it as a percentage because it's easier to talk about in the operating room, but really you should remember that it is a partial pressure driving the anesthetic from the lung into the blood, into the brain, where it has its effect. And if we look at MAC lined up of Des, Sevo, isohalthane, and xenon here, you can see that the MAC of desflurane is about 6%. Sevoflurane depends upon age quite significantly and has a range. Isoflurane somewhere around about 1.2%, and halothane is the most potent, but it's of historic significance mainly. And so of the commonly used inhaled anesthetics, isoflurane is the most potent. Some clinical factors affecting MAC. Well, gender doesn't affect MAC. It doesn't matter whether you're male, female, whether it's a 1 hour, 5 hour surgery, whether you're black, white, red, or green. Physiologic variables, assuming that you're not severely hypotensive or severely hypoxic or severely hypercarbic within usual variation, physiologic variables don't have much effect on MAC. Thyroid disease, if you're not concurrently either hyper or hypothermic, no temperature change, just hypo or hyperthyroid, no effect on MAC. And as mentioned previously, decerebration, or separating the cortex from the spinal cord, does not change MAC, suggesting that MAC is a spinal cord mediated effect. Things that decrease MAC, any co-administered anesthetic, lidocaine, which we often give with propofol to reduce the pain of injection, midazolam as a pre-medicament, fentanyl, drugs that have alpha-2 agonist effect like dexmedetomidine and clonidine, pregnancy with its elevations in endorphins and progesterone, acute alcoholism, because alcohol, if they're acutely intoxicated, they're already half asleep, chronic amphetamine use because they've depleted norepinephrine in their brain, and being cold all decrease the MAC. There are some other ones, severe hypotension and severe changes in sodium, but those are the main ones. And things that increase MAC or require more anesthetic to keep a patient, 50% of patients, from not moving to incision. Chronic alcoholism, acute amphetamine use where they're all ramped up on catecholamines, and where they're warm, temperature goes up, MAOIs, monoamine oxidase inhibitors, and changes in sodium, specifically hypernatremia. So hyponatremia reduces MAC, hypernatremia can increase MAC. The concept of vapor pressure is important, and our volatile anesthetics are supplied as a liquid, and in the temperature that they're usually at, they are in that liquid state. And when the volatile liquid is poured into the vaporizer, some of those liquid molecules will go up into the vapor phase and bombard the walls of the container and create a pressure known as the saturated vapor pressure. Each inhaled anesthetic has its vapor pressure, with sevoflurane being approximately 160 millimeters of mercury, isoflurane being approximately 240 millimeters of mercury, and desflurane having the highest vapor pressure at approximately 660 millimeters of mercury. Now, nitrous oxide is a gas at ambient temperature, but how can we get it into a liquid? In our blue cylinders, we put it under very high pressure, and therefore nitrous oxide is a liquid in those blue cylinders that is going up into the gaseous state. When the liquid is used up, then you just have the gas left, and your pressure gauge starts to move downward. If we look at vapor pressure at 20 degrees centigrade in millimeters of mercury, as I mentioned, desflurane is the highest vapor pressure, 660, meaning if you poured that out onto a counter, it just wants to go poof up into the vapor phase. While sevoflurane has the lowest at 160, and isoflurane and Halthan are very similar at 240. So 160, 240, 660 is the vapor pressures that you should probably remember. Now, I'm not the greatest artist in the world, but I drew this just as a representation of vapor pressure and a vaporizer. So assume that you have oxygen and air as your gases, fresh gases coming in over top of the vaporizer, and you're delivering isoflurane that is a liquid in the bottom of the vaporizer. Remember, some of those molecules are up into the vapor phase, bouncing against the walls till equilibrium is reached at the vapor pressure of the liquid anesthetic. So in the total environment of this liquid anesthetic, remember from general chemistry that the partial pressure of every gas that's present has to equal the total pressure of the system, which if at 1 atmosphere, that's sea level 760 millimeters of mercury. The vapor pressure of isoflurane at 20 degrees, it's important to say at 20 degrees because vapor pressure changes with temperature, but at 20 degrees, it is approximately 240 millimeters of mercury. So the partial pressure of isoflurane, approximately 240 millimeters of mercury, plus air and oxygen mixed together have to equal total pressure in the system of 760. So the partial pressure of isoflurane is approximately 238, 240 over the total pressure in the system, 760, or 31%. So at equilibration in this closed container, isoflurane would reach a concentration of approximately 31% above the liquid. Therefore, you need a variable bypass vaporizer. That is where some of the fresh gases go through a variable bypass over top of the liquid in the vaporizer while some bypass it. Otherwise, you're picking up 31% oxygen in the case of isoflurane. In the case of sevoflurane, same idea. Vapor pressure is 157 at 20 degrees. Total pressure of the system is 760. Divide those two together, and you would have 21% above that liquid. Again, emphasizing the fact that we need a flow-over vaporizer to deliver SIBO and isoflurane. Desflurane, because of its vapor pressure being so high, 660 millimeters of mercury out of a total of 760 at 1 atmosphere, and at 20 degrees, we should always express vapor pressures at the temperature. Desflurane, because of its high vapor pressure and desire to go up into the vapor phase, we cannot use a variable bypass flow-over vaporizer, but a specially designed one which has a heated chamber, closed environment. The closed environment heated chamber goes up to 39 degrees centigrade, creating a vapor pressure of 2 atmospheres inside of it. And think of it as almost like an injector into the system, and allowing you to deliver titratable concentrations of desflurane. So it's the vapor pressure of why this vaporizer had to be developed that is plugged in, warms up to 39 degrees, creating a vapor pressure of 2 atmospheres inside of that vaporizer. So some of the factors affecting vapor pressure, we said when we express a vapor pressure of 160 SIBO, 240 ISO, 660 desflurane, that we should say at 20 degrees centigrade, because as temperature goes up, those little molecules have more kinetic energy, and they create a higher vapor pressure. Vapor pressure increases with increases in temperature. Solubility decreases. It leaves the liquid state and goes up into the vapor state. Just like heating water, as you heat the water, you get steam. Independent of the volume of the liquid. As long as there's any liquid remaining in the container, the vapor pressure is independent of the volume, i.e. like the nitrous tank. As long as there's some liquid in it, the pressure above it, pressure in the tank stays the same. And it's also independent of atmospheric pressure. So vapor pressure is the same at sea level as it is at, say, for example, Denver, Mile High. And that's a good segue into what happens to vaporizers when you take them up to a different altitude other than sea level. It's important to remember it's partial pressure and not the concentration that's important in the concept of MAC. Although we talk about MAC as a percentage, as mentioned previously, we should think about it as a partial pressure, because that is what is actually necessary for driving the molecules into the lipid membranes and into the effector organ of the brain to provide general anesthesia. The take-home message is that there's no change in the vaporizer dial necessary for either iso or sevoflurane if you take a vaporizer that you calibrated at sea level and took it up, say, for example, to a Mile High at Denver. I'll show you a graphic representation of this in a moment, but except for the fact, just accept it, that you do not have to change your vaporizer dial. Your vaporizer will put out a constant partial pressure, not a constant percentage, but a constant partial pressure to the patient. However, desflurane in its own little environment does need to be altered. The dial actually would have to be increased, turned up, higher concentration if you took the desflurane vaporizer up to altitude. So let's look at this as an example. Isoflurane at 6,000 feet altitude, the atmospheric pressure there instead of 760 is approximately 610. Let's say we've turned on 2% isoflurane, and in actuality, more than 2% isoflurane leaves the vaporizer. Why? Because the pressure above the liquid, instead of being 760, is only 610, and so a little more of those molecules can jump up into the vapor phase. So even though you have it set at 2%, it delivers higher than that at the lower pressure, higher altitude environment. And if we take the 240 or so vapor pressure divided by 760, remember that's about 32%, 32% above the liquid. If we divide 244 divided by 610, that's about 39%. So what it's saying is we're actually delivering a higher concentration because there's less pressure pushing down on that liquid, preventing those molecules from jumping up into the gaseous state. And so if we multiply it out, 2% at 760 is approximately 15 millimeters of mercury. 2.8% at 610 is approximately the same, and you really don't have to change the dial because you get a similar partial pressure delivered to the patient. You may have to go over that several times to fully understand that, and please feel free to stop and rewind and listen again. But the next topic is desflurane at altitude. Now this vaporizer is in its own environment. Remember, it's 39 degrees. And at 39 degrees, it's 2 atmospheres of pressure. Let's say we set a desflurane vaporizer to 10%. It will deliver 10% because it's in its little closed environment, not affected by the reduced atmospheric pressure at 6,000 feet elevation. Well, 10% at 1 atmosphere, or sea level, is 76 millimeters of mercury in partial pressure. 10% at the 6,000 feet, where the pressure is only, atmospheric pressure is only 610, is only a total of 61 millimeters of mercury. So you really have to increase the dial to get the same partial pressure, and you'd have to increase approximately up to about 12.7% from 10% when you're at this higher altitude to deliver the same partial pressure, which is important for determining which patients will move and not move to incision. Now you can make errors in vaporizers when you fill them. Now this is much less common than it has been in the past because of the special caps that are used in filling apparatus used to put the liquid into the vaporizer. But several things that you do need to know, that if you're thinking about vaporizer filling errors, you should think about what's the agent, what's the vapor pressure, and what's the MAC of the agent. For example, if I put isoflurane in a halothane vaporizer or halothane in an isoflurane vaporizer, since they have the same vapor pressure, they deliver the percentage that you have on the dial. But the percentage on the dial is a different MAC because halothane is more potent than isoflurane. Now, if I happen to have an old enflurane vaporizer and had sevoflurane, I could put sevo on an enflurane vaporizer, dial 3, 5% or whatever, and that's what you would deliver to the patient because the vapor pressures are the same. Now think what would happen if you put desflurane in a variable bypass vaporizer like sevo iso. It could be catastrophic because desflurane would just go poof up into the gaseous phase. More than 80% would be desflurane in the vapor. You get a massive overdose to the patient, possible hypoxia. So when you are asked about vaporizer filling errors, and usually this is something for the in-training exam, it's not so much a clinical problem per se, but to help you understand vapor pressure, MAC, and filling of vaporizers. Now blood gas partition coefficient is our next topic, and this refers to the blood solubility basically of the volatile anesthetic, and it describes the affinity of the anesthetic for 2 phases and the partitioning of the anesthetic between those 2 phases at equilibrium. By definition, equilibrium is when there's no difference in partial pressure. It's equal on each side of some space, for example, blood and gas space. Isoflurane blood gas partition coefficient at equilibrium is 1.4, meaning there's more in the blood than in the gaseous phase at equilibrium. Partition coefficients are temperature dependent, as was vapor pressure, and the solubility of a gas in a liquid decreases when the temperature increases. More of it goes up into the gaseous phase, less soluble. The lower the blood gas partition coefficient, for example, desflurane, very low, sevoflurane, very low, isoflurane, not so low, but the lower the blood gas partition coefficient, the lower the solubility in the blood, and as we'll find out farther on in this talk, the faster the onset and offset of the volatile anesthetic. So, looking at the property of blood gas solubility here, you can see that desflurane, 0.42, much more soluble in the gaseous phase than in the blood. Sevoflurane, low blood gas solubility. Halothane, quite high blood gas solubility. Here again, partition coefficients showing nitrous oxide compared to desflurane, very close in that low blood gas solubility or quite fast onset and offset. So we tend to line up onset and offset as des and nitrous fast, SIBO fast, iso not so fast, and healthy quite slow. And if you look at not just their blood gas solubility, but their fat blood solubility, you can see that iso and SIBO are very similar. And it kind of bears out that the awakening times from SIBO is quite similar to isoflurane after quite a few hours of anesthetic delivery, because the fat takes up a large amount of it, and it can then have to come out of the fat into the blood and be exhaled. So at long duration anesthetics, sevoflurane's performance as time to awakening may look more and more like isoflurane. Let's talk briefly about anesthetic uptake and distribution. As we turn the dial on our vaporizer and turn up our fresh gas flows and alter our fresh gas flows, we are attempting to deliver the inhaled anesthetic to our breathing circuit, to the patient's lungs, into the arterial blood, and into the patient's brain. When we turn up our fresh gas flow, it delivers more quickly. The equilibration occurs within the breathing circuit. And there's some other things that we can do, like turning up our ventilatory rate or minute ventilation to speed the onset of the anesthetic state. Turn up our concentration, ventilate more and deliver more to the lungs, turn up our fresh gas flows, all things that we can do to speed the uptake of the inhaled volatile anesthetic. Now let's look at anesthetic uptake again with this partial pressure concept. Remember that 1 atmosphere is 760 millimeters of mercury. When you look at oxygen, which we're all familiar with, 21% oxygen, 21% of what? Of 760, meaning that the air around us has a partial pressure of oxygen approximately 160. It is reduced to about 150 by vapor pressure in our trachea and reduced down closer to 100 by CO2 and vapor pressure effect in our lungs. And then down to 95 because of some physiological shunts in our body. 1% isoflurane now, if we say 1% of what, or 1% of 1 atmosphere, that's 7.6 millimeters of mercury isoflurane partial pressure. So we're going to think of anesthetic uptake as we're altering the partial pressure in the alveolus. And what goes on in the alveolus is what goes on in the brain very quickly. So it's the rate of rise of the partial pressure of the anesthetic agent in the alveolus, not the concentration, but the partial pressure. It's not the amount dissolved in the blood that correlates with the onset of the anesthetic state. Again, it's the partial pressure. As it rises in the alveolus, it drives it into the arterial blood, drives it into the brain, and we have a rapid rise in anesthetic uptake. Now, there's some factors that affect this rise in partial pressure, delivery factors and things that remove it. Let's look at the side of delivery first. If we ventilate a patient more, we increase their minute ventilation, specifically their alveolar ventilation, it increases delivery. The soluble agents tend to be affected more than the insoluble agents. And so the soluble agents would be isoflurane, the insoluble agents would be des and sevoflurane. We can turn up our inspired concentration from 1 MAC to 2 MAC and rapidly increase delivery. If we combine nitrous oxide with our inhaled anesthetic, sometimes, although it's not super clinically important anymore, the second gas effect can speed the onset of the alveolar partial pressure. And then we can reduce the size of our system. If our circle system was smaller, for example, we could increase delivery to the patient. Loss, if a high cardiac output is present, lots of blood is going by the alveolus, it tends to pick up more of the anesthetic, and so the partial pressure doesn't rise as fast. Now, that sounds counterintuitive, but the patient who's anxious with a high cardiac output has a slower rate of rise of the partial pressure in their lung because of all that blood going by, as opposed to the shocky patient, trauma patient with a blood pressure that's low and a low cardiac output has a very fast onset of the anesthetic state, and small changes in your vaporizer dial result in quick changes and rise or fall in the alveolar partial pressure. VQ mismatch, such as example, a one lung ventilation when you're tube goes down too far, endobronchial. You can have slowing of the rate of rise of the partial pressure. So some of the clinical factors affecting, we've mentioned some of these before, the low cardiac output state, which will speed the onset of the anesthetic state with the soluble agent isoflurane more than the insoluble des and sevoflurane. An endobronchial intubation, where a tube goes down the right mainstem, for example, will slow the onset of the anesthetic state. You have one whole lung that's not receiving the volatile anesthetic. And it's going to affect the insoluble agents, des and sevo, more because iso actually has less effect, the soluble isoflurane, than does the insoluble des and sevo for this effect. Right to left shunts, the cyanotic heart lesions, such as tetralogy of flow, the bad heart lesions, slow the onset of the anesthetic state. When I say bad, I'm really referring to the blue ones, where the patient has right to left shunting, hypoxemia. Those slow the onset of the anesthetic state. While left to right shunts, an example being a simple VSD, will have little effect on the uptake and distribution of our volatile anesthetics. And Dr. Hess will be talking more about this in detail. So to speed the onset of the anesthetic state, we can choose a low blood gas agent like DES or SEVO as opposed to ISO. We can turn up our vaporizer setting, over pressurization it's called, increase our fresh gas flow, for example, from 1 liter per minute to 8 to 10 liters per minute. And there's some other things that we can do, like collapsing our rebreathing bag. FAFI curves are used to show uptake and distribution. And on the y-axis here, you can see FA over FI, or the alveolar over the inspired. And you can see that when FA over FI equals 1, that means what you are delivering or inspiring to the patient is equal to the alveolus. There's equilibrium between what's on the dial and what's in the lung. And you can see that with nitrous oxide and desflurane, it doesn't take too many minutes, and it will rate close to whatever's being on the dial being what's in the patient's lung, and by assumption, the partial pressure in the lung equals the partial pressure in the brain. So uptake and distribution of the low solubility agents, nitrous oxide and desflurane, very fast, and sevoflurane, very fast, while isoflurane, with its lower uptake and distribution speed, is directly related to its blood gas solubility, which is it's more soluble in the blood than the SEVO does, and nitrous. The halothane, which is very soluble in the blood here, you can see even at 30 minutes, we aren't anywhere near what's on the dial being what's in the patient's alveolus. Concentration effect explains why nitrous oxide has a higher FA over FI than DES, even though DES blood gas solubility is lower, 0.42 versus 0.47. Concentration effect meaning I'm giving more percentage of nitrous oxide than in desflurane. If I'm giving 70% nitrous versus only 6 or 7% desflurane, that's the reason why, concentration effect, that you see this faster FA over FI of nitrous oxide than DES. And if we show here an example of this, if you gave 70% nitrous oxide versus 10% nitrous oxide, just the higher concentration of nitrous oxide, as some of it's taken up, it concentrates what's left in the alveolus, speeds the onset of the anesthetic state. Obviously, we're not going to give 70% DES, but if we did give 70% DES and 70% nitrous oxide, and we're able to do that in a model, you would predict that because of the low blood gas solubility of DES more than nitrous, it would have a faster onset. So concentration effect explains the faster onset of nitrous oxide in FA over FI curve as opposed to desflurane. Now, how do these anesthetics get out of the body? They're eliminated simply by expiration by the number one method. Well, it could be potentially excreted, metabolized, perspired, but they are expired, unchanged from the lung in most cases. However, historically, if you went back and looked at halothane, 20% of it was metabolized. So metabolism was involved in the elimination awakening profile of halothane. As opposed to our modern inhaled anesthetics, SEVO, ISO, and DES, you can see that desflurane, 0.02%, is the least metabolized of our volatile anesthetics. And I call this kind of the rule of twos. Halothane 20%, Cevo 2%, isoflurane 0.2%, and desflurane 0.02%, lining them up from most metabolized to least metabolized. So if you see any questions about metabolism of volatile anesthetics, desflurane should be the one that you respond as the least metabolized. Now, nitrous oxide and xenon are less metabolized, but we're talking about the volatile inhaled anesthetics, des, iso, Cevo, and that's the way that you would line them up, Cevo being the most metabolized. Now, don't confuse what is metabolized in the body with the products that break down in the CO2 absorber. In other words, sevoflurane in a CO2 absorber can result in compound A, which we're going to talk about in the next series of part 2 of this 2-part series, and desflurane, which in the CO2 absorber can form carbon monoxide. This is not the metabolism we're talking about. This is body metabolism, not machine CO2 absorber metabolism. So anesthetics are eliminated by expiration. We'll end with this little portion on elimination. Here's a picture of the Italian countryside, bucket list trip to the Dolomites cycling this summer. Hope you have a great day and have learned something from this